תודה רבה לפרופסור סונדל. בזמן שאני אנסה לשים את המצגת השנייה, אני רוצה להזמין את פרופסור הווארד דובוביץ, מבית הספר לרפואה של אוניברסיטת מרילנד, והוא יציג לנו זווית קצת אחרת על אותו נושא. Howard, this is yours, and the stage is yours. 30 minutes. Starting now.
And 1 minute more, no? Okay. Shalom, hello. אני מדבר קצת עברית, לא מספיק. It's a big pleasure to be back in Israel. I was a stagiaire some years ago in Tel Shomer. Is this good, the sound?
Yes.
It's good? Okay. And so it's a real treat to be back in Jerusalem and Israel. And I'm hoping that what I show is going to be useful to folks here, but it really follows beautifully, I think, on what Knut has just suggested, the importance of doing controlled studies, and also the importance of doing it in Israel. And so hopefully I'm going to give you a glimpse of particularly 2 interventions. I really think the only 2 interventions that have been studied in child healthcare settings. And so I'm a pediatrician and very interested in how we should be doing more to prevent child maltreatment, and how we should be taking advantage of the possibilities in the healthcare system. So I don't know how many folks here are working in the medical, I know everyone's in mental health, but a few, okay, not so many. But so let's see. This is taken from the first page of one of the, perhaps the Bible of pediatrics, and it's a beautiful and rich description of what medical healthcare ought to be about. And here you see the concern not just narrowly on the child, but also naturally the importance of the social and environmental influences which have such a big impact on the health and well-being of kids. And so in my efforts to try and persuade other physicians and medical students of why this is important, it's very convenient to turn to page 1 of the Bible to show them, to make the case. I think I'm sure everyone here is persuaded, but for me, one of the exciting things about prevention, and you think of the kinds of interventions that we've already heard about today, is that if we are effective, then really the benefits of our interventions should be far beyond preventing child abuse and neglect. And there should be many benefits for the family and the kids in terms of their health and development that we might see. And I think this is not just being clever with semantics or words, that to shift the paradigm, particularly medicine, from preventing the bad stuff, preventing child maltreatment, and really what this is about is how can we promote children's health, development, and safety. So here is the first study that we've been doing, and it's really work over the last 10-12 years that I'm going to try and quickly summarize today, a project called SEEK. And I don't know if it's true in Israel, but in the States, every program, I was told, needs some cute little short name, right? So, a safe environment for every kid, SEEK. Now, for Israel, I think the question would be in your Tipat Chalav, or maybe in Kupat Cholim, the primary care that kids get. Could this be the kind of setting where this intervention, but tested in Israel, could work? And briefly what you see summarized here is what does primary care, preventive care, everyone knows what I'm talking about when I say primary care?
Yes.
Okay, good. It's the routine checkups that kids get, and you see the different intervals. And what this whole system of care aims to do is to prevent or at least detect early problems with the hope of preventing a variety of bad outcomes. Why is primary care potentially such a great opportunity? For one, in Israel, I think it's even better accepted perhaps than in the United States. I hear very good reports, for example, about Tipat Halav. It's well accepted, it's institutionalized, so we're not talking about building a whole new infrastructure. And in days of budget problems, this is not a small thing. The goal of prevention is integral to what this whole system is aiming to do. At least for 30 or 40 years, we've been talking the talk that the concern should be about the child and what's around the child, particularly the family. One of the advantages that we have in the healthcare system, I think, compared to my colleagues in the child welfare system, is that very often there's a good relationship. And as we've heard a few times, when we compare different interventions, the relationship is so important. So most of the time, parents like the staff who are providing primary care. There's a nice rapport, and we have less or no stigma of being involved with us. And especially in the first few years with little babies, but even 2-3-year-olds, there are lots of visits. And so arguably, if you have such a system, you have a good opportunity, and with that opportunity you have even a responsibility to see how you can be most helpful. Okay. So in that context of how in the United States most kids get primary care, we have developed and implemented this SEEK model, and quickly I'll describe it. It begins by training the health professionals, and these are pediatricians, family doctors, and also nurses, pediatric nurse practitioners, on how to address these psychosocial problems. Because, for example, maternal mother's depression is something that pediatricians had not been taught what to do. So it was important to prepare them. We gave them a simple screening tool that parents, mothers usually would fill out while they were waiting for their child to be seen. And we had to recognize the constraints of a busy practice. People are moving fast, and so it has to be practical, right? Otherwise, we realized we were going nowhere. And the principle was that when parents would fill out the screening questionnaire, and I'll show you more in a minute, that there would be a brief assessment of the identified problem, followed by the initial management. So the concept was, we didn't delude ourselves into thinking, let's say that drug substance abuse was a problem, that this would happen in the pediatric setting. No. But in a few strategic minutes, how the health professional could potentially play a pivotal role identifying the problem and then referring, connecting the family to other resources in the community. So it was the initial management, and an important part of the model included a social worker. And we started out in Baltimore, and in many of the urban settings, clinics do have access to social workers, less so in private practices. But there were some other resources we developed, and we had to work closely with other agencies in the community. So briefly, this is the SEEK model. Just to give you an idea, in training the professionals why they should care about this. These are people who are busy, they think they've got enough on their plate already, now you're telling us to do more. We had to begin to explain to them why this problem was important for kids, important to their practice. So, for example, again, using mothers who are depressed, what do we know about how prevalent this is, its impact on parents, on families, on children, and even some studies that have shown quite nicely how treating the mom benefits the child. So using the evidence to say, guys, there's a good argument on why this problem is important, then teaching them again how to briefly assess this and what to do, the initial management. So basically preparing them to play a limited but important role in addressing these psychosocial problems. And here you see, taken from looking at the literature of some of the big problems that have been identified as risk factors for child maltreatment. It's not everything, and here in Israel obviously they might be different, but applying what we know to try and tackle these, at least these 4 problems. The questionnaire that we developed, we had a community advisory committee, it had both parents and it had health professionals, and they told us it had to be short, easy to read, answers yes, no, and it was voluntary, not a very important issue. People could choose, obviously, what to disclose or not. And this is what it looked like. What's especially important is, you'll notice, maybe I don't know if you could read at the back, but how this all gets framed. How does one help parents disclose sensitive information? And so, maybe it's the next slide. Yes. So striking an empathic tone of being a parent is not so easy. Very important that we're doing this universally. We're not picking on you because we think maybe you're using drugs. Providing a context. So for many years in child health care, we have worried about kids being safe. Now most of the time it has been things like smoke alarms or wearing a bike helmet and stuff like that. This is building on the notion of safety that has been around for so long. And this is what I just said, injury prevention. And here you see some examples, and where we could, we took from other research. Depression is probably the best example where there's been a fair amount of work on how even asking just 2 questions does pretty well in screening for depression compared to clinical interviews. So we screened at the regular checkups, not when the kids were coming in for what we call our sick visits, kids that we didn't think was a good time. So one of the first, maybe the main study hypothesis was that this model of pediatric primary care would help reduce child maltreatment, and we measured this 3 different ways by what parents described as how they would discipline their kids, looking at the children's medical charts to see what was documented for both neglect and abuse, and thirdly, gathering data from the state to see about reports to CPS, Child Protective Services. And just to give you an idea, here you see on the left that we have these different practices, or clinics you could say, that are randomly assigned to get either the SEEK model with the pediatrician, that questionnaire, and the social worker, and at the bottom, they are receiving just the standard routine pediatric care. So we randomized the clinics, and then from both of these groups, we recruited a subset of mostly mothers to evaluate whether this model made a difference. And we did it initially, and then up to 12 months later, and then towards the end of the study, we gathered the data from the records and from CPS. People pretty clear about the model? Okay. The participants were moms bringing in young kids, spoke English, the children were not in foster care, and as I said, they were bringing the kids for a checkup. This is, I'm going to just show you from two randomized controlled trials, SEEK1 and SEEK2, and you'll see very different samples, very different populations. This SEEK1 is from a very low-income urban population, mostly African American, with, you see, relatively few people beyond high school or more, and only a third are employed. This is from the suburbs, mostly. A very different, mostly middle-class white population. The moms are a bit older. 90% have college or more, and you see most are married, and over half with family incomes over $75,000. So two very different samples. High risk, low risk. Okay, this is looking at the kids. You see the numbers that we had. Children are younger in the high-risk sample. About half are boys, mostly African American, mostly white. This is the government health insurance, and a marker for poverty. This is private insurance. Okay, so when we looked at what parents reported on the conflict tactic scale, some might be familiar with this measure. I'm just showing you the significant changes from the start to follow-up. And what you see in the first study is how the parents reported a significant decrease in the severe physical assault. This is stuff that I think in most countries would clearly count as physical abuse. This is not a slap on the bottom, okay? In contrast, in the low-risk sample, there was actually very little of that behavior reported, and instead what we had was a decrease in the more minor physical assault, okay, but also in less psychological aggression, less putting the kid down, screaming, yelling, telling the kid he or she's bad. Probably, in most of the United States, this would not count as abuse, but still, clearly, I think, potentially damaging to children. So this is what the parents themselves reported. When we looked at the medical charts, and we were interested in neglect, and one of the measures is non-compliance, where the doctor or nurse actually documented, and by the way, we did not train them to do this, that there was a problem, that the parent was not following the instructions, that a certain treatment was recommended, didn't happen. Here you see that particularly when you look at after the model gets implemented, before the groups are similar, okay, after, what we find is that there's significantly less in the yellow or orange intervention group compared to the controls. I should point out there's a problem in, you might ask, boy, why did the problems go up when the model was introduced in both groups? It's a problem that we have that the time of observation, the period of observation, is much longer here. Remember, especially if you're starting with babies, the before period is just maybe 6 months or 4 months. So there wasn't much time for these problems to occur. So that's the reason for that. But anyway, we see that about half the rate of this problem documented in the medical charts. And we looked at problems of kids being immunized, and you see a somewhat similar pattern that the intervention in SEEK1 is showing a nice benefit with far fewer of the kids having this problem of not being adequately immunized. And then when we look thirdly at reports to Child Protective Services, here too you see in SEEK1 a nice benefit where the rate of these reports is about a third lower compared to the control group. So in 3 different measures, at least in a high-risk sample, we find that maltreatment appears to be lower. I should say that for the medical records and for the CPS, there were very few problems documented in the low-risk sample, if you're wondering what happened to them. So it was only on the mother's self-report about how they discipline and the psychological aggression that we had that finding. So what do we think are some of the strengths of the SEEK model? Some encouraging findings in 2 randomized control trials with moderate size samples, both high and low risk. And it fits for us very nicely in an existing system of pediatric primary care. And I haven't shown you it, but one of the big questions back home is, well, how much time did this take? And we have measured the time and we're working on the cost effectiveness. Interestingly, it did not take much more time to do this model. So, the other, shifting gears, okay, to a very different kind of intervention that has aimed to prevent parents of newborns with regard to shaking and causing head trauma. Has this been a big or public issue in Israel? Sorry?
Once in a while.
Not that big, but last week.
Last week, okay. So this is a relatively, well, we'll see. There's actually a question about how infrequent, how often the diagnosis is missed, and how often there can be mild shaking. But obviously when it does happen, it can be devastating. So either causing kids to die or to be left in a terrible neurological condition, perhaps for the rest of their lives. So here you see the known cases. Some years ago in the States, we also thought it was pretty infrequent. The severe cases are relatively infrequent, 20 or 30 per 10,000. But there's also some data from North Carolina asking parents in a randomized survey how often they shake their baby, and surprisingly higher numbers admitting that. So here you see what I've just been describing, that we've thought of it being, 17 per 100,000, I think I said 10,000. And this is the North Carolina data showing in that survey a much higher rate. So it started with a neurosurgeon in upstate New York who developed this program to teach parents about crying, and it included a videotape that taught parents how to cope with crying, how to put the baby down, take a time out, and also had an interesting element that they had a statement which the parents signed that they had seen this information, and because often it's the fathers or the boyfriends who are the problem, that they would share this information with anyone else who has access to the baby. What they found in this first study was a 47% reduction in cases. This is in upstate New York. And they did not have a control group. So the question, as Knut showed, well, maybe this was happening everywhere. circumstances were better, cases would be down. And they compared it to neighboring Pennsylvania, where they found that there was no similar decrease. So the conclusion was that this was a promising strategy. Some of the limitations of this DS model, many of the parents were not reached. The question, was the decrease maybe to other factors, other things changing in New York State? To what extent are the findings generalizable, even within the United States? You know, we're asking you, focusing on across countries, across borders, but sometimes we have the question back home across states or across counties where there can be big differences. And of course, are the findings reproducible? So Ron Barr, a pediatrician who for many years has been working on the problem of infant crime, has developed something called the purple crime model. And anyone who wants this handout, by the way, if you email me, I'll send you the PowerPoint, so I'm going to move quickly. But here you just see from the brochure that they developed for the period of purple crime. And basically, what they did in 2 randomized control trials as well was they had this little booklet, you just saw a page of it, and a CD, that, a DVD actually, that people could take home. They were given when new parents were leaving the hospital. Nice little bag, a little t-shirt for the baby, this booklet, and the CD. The comparison group were given just other information about safety in the home. And so some of the moms, families actually were recruited prenatally, others right after the baby was born. And then they had parents keep a diary, and in this diary, every day, they were supposed to document how much when the baby was crying, what the parent did when the baby was crying, holding, and also times when the baby continued to cry and cry and cry, but they would put the baby down and walk away. And then they followed up 2 months later in a phone interview. 2 minutes, okay. In the evaluation, what they found, here you see the evaluation of knowledge. And when they looked at what parents knew about crying, an important part of this was to explain to parents that, you know what? Crying is normal. It doesn't mean that you're doing something wrong. And we see a small benefit. Also, when they looked at the risks of shaking, what did parents know about that? Slightly more, 83 moving up to 85%, not significantly different. Knew that shaking was bad. So more on the evaluation. When they examined the behavioral response, the first slide was knowledge. Now looking at what did the parents report in those diaries that they actually did. They found that there was a slight but not statistically significant benefit in terms of how parents responded to the crying. When they looked at how often parents shared the information, we see a few benefits. And in one of the studies, when the babies were crying, there was more appropriate contact during the baby's distress. That was significantly different. Some of the strengths have been that these are large evaluations with several thousand families, again randomized controlled trials, and there was strong fidelity to the model. So it was a simple model, a little packet that parents got, and as far as I know, there was good fidelity. Some of the limitations, it was only evaluating mothers, and we know that abusive head trauma is mostly at the hands of men. Really small differences in terms of knowledge and self-reported behavior, not the strongest outcome. and they didn't make any attempt to actually measure abuse of head trauma or shaking.
I'm standing up.
So I thought you're just stretching your legs. Actually, your timing is perfect because, so here we have an example of some evidence. We have really just one study from New York State suggesting a big improvement. Some skepticism about the design. Mark Diaz, who moved from New York to Hershey, Pennsylvania, has been trying unsuccessfully to replicate this model. So all today we've been hearing about evidence and how important it is. Here we have a good example where we have a little evidence, but when, this is a Talmudic question I think, when is there enough evidence, and I'm not sure. So the question I'm ending with is, can and should problems like this be tested or applied in Israel? Toda rabah.